Okay, short week, Monday holiday, that's always nice. So, now that you're studying epidemiology and learning the jargon, learning concepts, learning the principles, did anyone spot any epidemiology news stories this past week? Yes. I'm going to say it wrong. The flu transmitted by okay. Huh.
Tell us more. I want to say avian flu, but that's not right. That's birds, right?
Right.
I just heard it on NPR when I was told. I did not stay informed in this way. And North Carolina Department of Public Health, the division of, that was interesting, the division of the Department of Health announced their first death from such and such flu, which is related to starting by mosquito.
Who can look that up for us? So I see you reaching towards your keyboard. You've piqued all of our interest, so we're going to find out what's going on in our neighboring states. Do you remember what part of North Carolina? Okay. Okay. West Nile. Okay. Okay.
North Carolina Department of Health virus
Interesting. So we'll have to keep an eye on that. Has Tennessee had any cases reported? And as you folks are working on that, I didn't see anything in sort of press, newspapers, but this is American Journal of Epidemiology, and this is one of the journals that epidemiologists follow. It's a journal that's associated with one of our professional organizations, Society for Epidemiologic Research, and this is one of my go-to journals to keep myself up to date with new epidemiologic methods or new studies being reported in the literature. And in this edition for September 1, there was an article on body mass index in young adult obesity trajectory and premature mortality. And so we're going to be talking about a little bit about premature mortality today. And so that was interesting to find. And let's see what their abstract says. The participants who reported being overweight or obese as young adults had mortality rates that were 19% and 64% higher, respectively, than those of their normal weight counterparts. And their 19% mortality rate had a confidence interval of 12 to 27. and the 64% mortality rate had a confidence interval of 52 to 78. What do those confidence intervals mean, and how should I use them? Okay, when we calculate rates, odds ratios, relative risk, those are called point estimates. They're a point estimate statistic. In order to determine how precise our point estimate is, we then calculate a 95% confidence interval, a 90% confidence interval. Most often, we calculate a 95% confidence interval. It's an arbitrary selection, but that's what we will find most often in the literature. And so there was a mortality rate of 19%.
Sorry, guys. Keep sharing one of them.
Okay, online, let's see, I know that Fred is on and Joy. If your audio is on, could you please mute yourself? We're hearing some squeaks, flops, other noises. Okay, we were talking about 19% mortality rate with a confidence interval of 12 to 27. So we have a 19%, and the confidence interval informs us that the true rate most likely will fit in that interval from 12 to 27. The tighter that interval, the more precise our estimate of rate, relative risk, odds ratio, whatever. This is another go-to journal for myself as an epidemiologist, Annals of Epidemiology. And two that are because of that. Aisha, go farther over. Yeah, push that. That's right. Yeah, I'm not kidding. Try to talk to her while it's quiet. Yeah. Aisha, can you please mute? It's stuck. Thank you so much for doing that.
Maybe she could log out and log back in.
Thank you for those suggestions. Keep communicating with her. It's wonderful to have multiple licenses. This is associated with American College of Epidemiology, another one of professional organizations.
Sure. Yes. The numbers are arbitrary. I'm just having a hard time figuring out how they calculate it.
Okay, yeah, no. The numbers
Yeah, she got it.
Okay, very good, very good. The numbers are not arbitrary. There are few formulas for calculating confidence intervals, and I will provide those to you just as a source of added information. There are formulas that you do not have to memorize, but you can learn the pieces that go into that allow us to depend upon those as units of precision.
So the closer the confidence interval is to 100, the more accurate
the confidence interval goes around the point estimate. So the point estimate could be 1, it could be 50, it could be 75. So it's going to go around that point estimate, not necessarily 100.
You had mentioned like the tighter it is.
The tighter it is, meaning if my point estimate is 5 and I have a confidence interval from 4 to 6, that's a tight interval.
Okay.
If it's from 1 to 250, then that's a large interval and less precise. And usually it's the measure of preciseness is associated with the sample size.
Okay.
Did we get any more information about West Nile?
What I read said Charlotte, but that could very well be who was reporting it.
Sure. Okay, let's keep our eyes open for that report. Thank you, Amy. All right, so you now are hopefully becoming familiar with the course, with the text, with the materials that are on D2L. Any problems, any issues? Am I meeting your expectations for this class? Anything? Any feedback? Yes.
You're awesome. And also, just making sure, because when I saw my last quiz grade and then I look on grades and it's like weighted and you have it all calculated, and I was like, I thought those quizzes were not.
Yes, no. Those quizzes are not part of your grade, and we are not even using D2L to calculate our grades. And so when you put a course together in D2L, it puts a grade book together for you, and we are not using that grade book.
This is probably something I talked to you guys about where the answers from. I actually couldn't see some of my answers, and I couldn't miss my quiz. And it could have been my internet or my computer thing, but not for my thing.
So you weren't able to submit.
I was trying to save all my answers, and I refreshed it, and it kept telling me.
Same thing. Okay. So what are the procedures that you go through when you take a quiz?
Well, the first one I didn't have a problem with. It was just
The
this
second
one.
You can just click on the under assessment and then the quiz, and then it opens up, and then start quiz, and then you start quiz, and then it pops up, and then you should be able to save each one as you answer it. And then at the bottom, when it's done, save all responses. Then it should go maybe if you did.
Yeah, it may have been like a problem with my computer or D2L or something.
I could say 3 of my questions. I couldn't say the rest of them.
Okay.
I didn't sweat it too much because I knew it wasn't graded, but I didn't know if maybe you looked out when I mentioned that.
No, that's helpful information because that's feedback that we can provide to the D2L team, and they say, oh, D2L just gets quirky every now and then.
Right.
So, unfortunately, that's the only. But if it keep me updated on that.
And if a lot of people in the classroom were extension, it's probably that's a lot of people.
Right. Anything else?
Just a question we were chatting about before class about the content, and sometimes there are things in the slides that aren't in the reading, like relative rates, that wasn't in the reading. And then sometimes we don't get to every single slide. So as far as what we're expected to know, if it's a study for exam, can you just explain that?
The text.
The text. Okay.
Yes. And anything extra is extra.
Okay.
just for your benefit.
Okay.
But it is the text. We are following each chapter. There's so much that we want to teach you.
I have a question for the exam.
Yes.
You know, there's all these different formulas in the book and everything. That's for us to know, or are we gonna be able to have like a formula sheet, or how's that gonna work?
Yeah, you won't have the formula sheet.
Okay. But for the exams, we will have to calculate things.
Yes.
Okay.
They won't be smart.
Okay.
That's right. She did say that, right?
Right?
You know, your study guide, we do have one, but it basically looks like everything that it looks like the slides and the text. The week 8, we will be here from 4 to 5 to go over anything that you would like us to go over. And we will also, we're monitoring quizzes to see if there are some questions that everyone's having difficulty with. You know, what's the question? It's student. So we'll use that also to help monitor things. And also, you know, whenever you come to something that you're not sure of, you have a question about, either email me or Yang, and we'll either address it during class time or we'll get back to you.
I don't know if it's too early, but can you talk about the exam format?
The exam format is has a combination of multiple choice, true, false, and there are some open-ended questions. The exam, you will be allotted 90 minutes, and that is more than enough time. And so because of the size of this class, we're going to be taking the exam in 132, 136, whatever the computer lab is down the hall. And some of you will be assigned to begin your exams at 1 o'clock, and then the remaining will begin at 2:30. And if you are assigned 1 o'clock, you will most likely be finished before 2:30. You must be finished at 2:30, but one of the reasons why we're timing these quizzes so that you'll feel comfortable, making sure you get to each item rather than dwelling on a single question. Remember, if you're having trouble with a question, skip on to the next question so you can regain your confidence and go back to any questions that you're having difficulty with. Now, read the question slowly. Say to yourself, that says prevalence, that says incidence. It is very easy to get tripped up in the jargon sometimes, okay?
I feel like there's a kind of like a tricky question on the second quiz where it was like about the agent and the host and the and I was like, oh yeah, so and then it was like everything.
One I got turned up on too.
There are some, you know, even as I re-review the chapters and go through the questions at the end of the chapters, I realize, well, okay, I was fooled by that one also. You really have to concentrate and focus.
About the chapter question,
Mm-hmm.
doing some of those, doing them, and I know we go over some of them, but is there any way that we could put the answers to those so we, oh, they are in the book?
They are. The answers are at the end of the book. However, they just say, you know, A, B, C, and so. And that may be fine for some of the questions. If there are some questions that, okay, I know the answer, but it's still doesn't make sense, go ahead and we will provide further information to you in terms of how we might think through yeah, please, ask questions, best way to learn. Anything else? All right. So, speaking of questions, we did have some questions from either you or your colleagues. They were mostly the online students. And so, one question came in regarding surveillance with the possible implementation of electronic medical records, EMRs, also referred to now electronic health records, EHRs. Would a patient's medical history from their primary care physician be accessed by a hospital physician? If so, how would it affect epidemiologic collection of data? And, you know, electronic medical records are coming about because of the Affordable Care Act, and actually, you know, it is a requirement of the Affordable Care Act that electronic medical records be put in place. But you get caught in this quandary of, okay, fine, they're electronic medical records. Are they usable? Are they reliable? Are they the information in there valid? And do they link so that they can serve a purpose, an epidemiologic purpose? And I think that is where this question is coming from. If you see a physician on an outpatient basis, and then you are hospitalized, and hospitals have hospitalist physicians that serve patients in-house in addition to the individual's own physician. Gee, wouldn't that be great if the hospitalists were able to have access to prior data on the patient? But right now, even think about the Tri-City areas, think about the number of hospitals, they're all using different software. And so you may have the existence of the electronic medical records, but they can't talk to each other. And until we get a system that can communicate, just like I can communicate with you, they are not as much help as they could be for epidemiologists. They serve their purpose in a physician's office, particularly for billing matters. They serve their purpose in hospitals, but still very difficult to use for research purposes. The VA system has a national database that is quite robust and really can be used for research purposes. And, you know, it is national, and so we can at least be fairly confident using electronic medical records for a subpopulation of folks in the United States. Has anyone had any experience with electronic medical records? Yes, tell us about that.
I used to work for an ophthalmologist in my issues and history. Very much, and just from things like getting records from other institutions, sending them, it's pretty long way from that process. There's not a lot of communication. The nation has privileges in the hospital and the surgery center.
And when you were entering data, what type of data were you entering? Meaning numbers or whole sentences?
Well, there is like kind of boxes, like checking categories, like, you know, history and family history,
So some categorical or ordinal data. Go ahead.
One thing, I worked at ophthalmology one thing that you could do, which was nice, I never tried to get records from other places, but I could access med lists from Barclays with it. It works half the time.
Okay. Well, that's half the time. There's no time at all.
Different hospitals will have their own portals, like the Vermont hospitals are going to access the whole Vermont system on their own. And the IPC, the education consultants, is their own. So they can send data to they have separate portals.
Yeah, and that's that whole thing. We're trying to get to that communication, not linking. Often common are vaccination registries, state vaccination registries, where the data are maintained at the state level, usually the State Department of Health, and if a physician's office selects to participate, then they're able to, through the state maintained database, they're able to access the vaccination record of a child that may come in that they're seeing for the first time, and primary caretaker doesn't have the child's vaccination record, which most often the case, and so they're able to access that data that way. The reason why I was asking you what type of data you were entering, whether it was numeric or character alpha, there's an interesting new field of sort of natural language processing, where you are actually analyzing the words, because all medical records, you get some descriptions of the condition, the disease, of the whatever, and it's not all numeric, which is what we would need in terms of traditional data analysis. But the natural language processing helps to identify, if you want, all cases of Hep C, and for some reason that is not checked in all medical records, using some of the conditions and symptoms that are highly associated with that diagnosis. You can begin making groups of patients or subgroups of patients. Anyway, it's also being called big data research. Okay, that's one of the sort of the buzzwords that NIH is hitting, and researchers are hitting a new field for epidemiologists in terms of how does one analyze these large data sets, and what methods do we have that are robust enough to take into consideration these large amounts of data. If the database is large enough, you're going to find something that's significant, and so, are you going to get excited about that? And just a lot of things to consider as we prepare ourselves for being able to use electronic medical records appropriately. Let's see, down to the second bullet, would an epidemiologist trying to gather information for studies also have conflict with HIPAA rules and regulations? Are they exempt? Researchers are not exempt from HIPAA, and as you know, HIPAA is the Health Insurance Portability and Accountability Act of 1996. I read that again today, and I'm like, oh my God, 10 years ago. That's amazing. It was actually enacted in August 21st, 1996, and that was in President Clinton's presidency. And HIPAA protects health insurance coverage for workers and their families when they change or lose their job, and that was the primary purpose of the first part of HIPAA. And then the second part of HIPAA, known as the administrative simplification, which is always, you just sort of laugh, no. The federal government did it, they didn't simplify it. They really made it more difficult for researchers in terms of access to data. There's some interesting statistics from a study from the University of Michigan demonstrated that implementation of the HIPAA privacy rule resulted in a drop from 96% to 34% in the proportion of follow-up surveys completed by study patients being followed after a heart attack. When HIPAA rules and regulations came down, research consent forms expanded by multiple pages because of the standard wording that you have to put in the consent form. And consent forms are complex enough as it is, and having to go through and read all of that information, it's very legalese, and it sounds scary sometimes. And so, you know, you're a patient in the hospital, and you start worried about things that perhaps you shouldn't be worried about. But anyway, it's something that we do have to deal with. Actually, ETSU recently hired an individual that is our HIPAA privacy officer, Lindsay Daniels. She is a full-time employee now, and she's going to be, well, she probably already has created it, getting this up as an online module for HIPAA training. She's been going around the various colleges and providing one-on-one HIPAA training for those projects that we are involved with. Yang and I will be participating in a training because we're working on a project in which data are coming from the Children's Hospital. So those data are hospital data. They're responsible for those data. Even though the data will be de-identified, we will be HIPAA trained and certified and ready to roll once we get our training in. There was another question that came in and asked how the galley was quantified. We didn't get the specifics in Chapter 4. So, for example, this slide is extra information. It was mentioned, but the specifics of a galley was not included in Chapter 4. And so it is, you see the formula for computing it. DALY equals YLL plus YLD, and then further down we find that the YLL is the number of deaths times standard life expectancy, and age of 75 was used in Chapter 4 with further explanation that it's not necessarily 75 all of the time. Once again, an arbitrary but common cutoff. The YLD is number of incident cases times the disability weight times average duration of the case until remission or death. And so it's this disability weight that can change and depending on who comes up with the weighting. They use, if you're using different data sets, the weight that you come up with or compute may differ. So it is not a constant across the board, and the disability weight ranges from 0 to 1, and often determined by World Health Organization, any one of our large health organizations, CDC, The example in Chapter 4 was the global burden of disease study. And so there's some information on ADALIS for those that are interested in that. So let's go to an example. We talked about, okay, at the end of the chapter, there are some review questions. I suggest you go through each of those questions. They're good questions, and once again, they get you into the practice mode of focusing on every piece of information that you're provided in the question so that you can answer appropriately. This was review question 5, and it states the incidence rate of a disease is 5 times greater in women versus men. No difference in prevalence, though. So we have incidence rate greater in women versus men. What's the best explanation? And I'll let you read through those options. So let's start with the information that we're provided. What's an incidence rate? Number of new cases over the population at risk, usually multiplied by some constant, takes in time. Okay, incidence rate, new diseases occurring more often in women versus men. Okay, they have an incidence rate of 5 times greater. That's quite significant. What's the prevalence? Number of people who have the disease. Okay, so you've got men and women, 2 groups, 2 subgroups, and there's no difference in prevalence. But for some reason, I mean, not for some reason, you've got more cases occurring in women. And so if you have more cases occurring, you might say, geez, shouldn't the prevalence be higher? There's more cases occurring. But why are you not counting more cases? What's going on that keeps the prevalence similar for men and women? If you can't count a case, why can't you count a case? They're dying. They're dying. Okay? And so what gets you now close to what's happening? Okay, I hear B and I hear C. So B, case fatality from the disease is greater in women. Case fatality from this disease is less in women. Okay, case fatality for B, that means that women are dying of this disease at a faster rate. Okay, there are new cases, many more new cases versus men, but they're also dying at a faster rate. Mm-hmm.
So if 10 or 6 shorter, if they got better quickly, wouldn't that also work?
And so is that duration of disease is shorter?
Also, yeah, with her, like the men were dying quicker than women, that's a short duration.
Right, but remember, there's more cases being found in women. And so, but the prevalence shows no difference. If the duration of disease is shorter in men, that would affect the prevalence.
looking at that picture of the steady state,
Mhm.
the two ways of the limit or lowering the prevalence treated by doctors and cure.
Mm-hmm.
So if the duration is shorter, then that would have less men in the pool that are still sick.
Right.
So would that lead to lower prevalence?
But the prevalence shows no difference.
Problem is there should be more women who show higher prevalence than men if they're producing or not, right? So that would only take care of making men prevalent
That's right.
less.
That's
That
right.
doesn't-
That's
that
right.
doesn't work.
That's right. That's right. That's right. Remember, there's no difference in prevalence, men versus women. What we're worried about is that 5 times the incidence being 5 times greater. And you would expect incidence is higher, you're going to have more in the population at a certain period in time or a certain point in time. But the only way one of the ways to take care of that is for case fatality to be higher in women than in men. Okay, so this is where you see a question like this, and what you want to have in your toolbox is the operational definition of incidence rate, prevalence, crude all-cause mortality. How does that affect your numbers? Case fatality, how does that affect your numbers? Duration. And effect. Okay, let's see. I'm all for reviews. I have to keep reviewing things before they stick in my brain. Okay. All right. You've already provided the definition earlier. Prevalence, total number of existing health events, either a point prevalence or a period prevalence. Often that adjective, you will not see that adjective in a journal article or in the newspaper. It's just prevalence. Incidence, number of new health events that occur during a given time period. Incidence is a measure of risk. Okay. Another thing. Okay, when you say incidence, think of risk. Prevalence is not a measure of risk. Okay? Only incidence, only rates can be put in the same sentence as risk. Prevalence is an indicator of public health burden. How many cases do we have now? Is the prevalence changing over time? Should we be moving our resources around because we're finding that the prevalence of stroke is now higher than the prevalence of cancer? Remember your 2x2 table. When you freeze because you're being asked to calculate an odds ratio, remember your 2x2 table. It's comfortable. A times B divided by B times C. What is that? Odds ratio. And this 2x2 table will allow you to classify every individual in your study. We're interested in the exposure, which is often called the independent variable, and we're interested in the outcome, the dependent variable or the disease. Okay? Independent variable, exposure, dependent variable, outcome, disease. All terms that you'll begin to see are used interchangeably. particularly in journal articles. Relative risk and odds ratios are measures of association used to evaluate risk in epidemiologic studies. These are specific epidemiologic techniques, biostatistical techniques, but they come from the field of epidemiology. We claim them. They are relative risk is used for risk. Odds ratio is an estimation of risk. Remember, we can use relative risk with cohort studies, forward studies, they're called forward studies, prospective studies, longitudinal studies. We can actually see what's happening. Whereas with your odds ratio, you're using that with a case control study or sometimes a cross-sectional study. And it's an estimate of risk because you're not quite, sometimes you're not sure what came before what because you're using retrospective data. Let's begin. Simple formula, proportions. Numerator, denominator, and then multiply by a constant. 100, 1,000, 100,000. Doesn't matter. Just as long as you report it consistently within the same table. There's your rate, number of new events during a certain time period, number and group of population. You saw in Chapter 4 they began using the terminology of the mid-year population. Population, geographic population, county population, city population, they change over time. You've got some people moving in, some people moving out, and so the reason for saying that you're using a mid-year population. Usually you're not going to have a significant in or a significant out. Okay, so these are the learning objectives that we're focusing on for this week that are associated with Chapter 4. We continue to learn more about measures of disease, disease burden. With Chapter 4, we're getting very specific with death and mortality. And so there's some jokes about epidemiologists that all we're concerned about is death, but often a very common outcome for our study. And once again, we're talking about measures of disease impact. We learn a little bit more about rates. We learn a little bit about premature mortality or years of potential life loss, and understanding how epidemiology helps us to explain the measurement of disease risk, determination of disease causation, and evaluation of the effectiveness of intervening to modify the disease process. Now, disease causation is a crux of epidemiology, and so there were 3 items that were posted on D2L for this week. There was a journal article on television viewing and smoking, the hills, causation, and there was also an exercise. And we're going to use those materials. I have copies of those towards the end of the class so that we can begin discussing cause in groups. It is an issue that we grapple with in our research studies in terms of, is it a true cause? Has it been measured appropriately? Are there other variables that are affecting what we think is our risk factor? And so as we go through this semester, we'll begin to speak more specifically about cause and how the techniques that are available to us to test whether or not something is a true cause. So let's take a break, and we'll come back and discuss more of the specific concepts that were introduced in Chapter 4.
They all work together. Like they're all working. So it's like
years.
Okay, as you read, the focus of Chapter 4 is on mortality, a measure of disease impact, death from a disease. Mortality, once again, is a specific type of rate, a mortality rate, a death rate. It can be even more specific than a death rate. It can be an age-specific death rate, a gender-specific death rate. You can calculate a rate for any characteristic of a population. And to determine risk, once again, we need the rate. We cannot just use the crude numbers, cannot use the frequencies, the counts. Once again, crude numbers, frequency, count, terms that you will see that are used interchangeably. There were a lot of graphs that were presented in Chapter 4, and that was a reminder of how we use data over time. We often graph the data to make a picture, to help us understand a picture, 1,000 words, and an example of cancer death rates among men in the U.S. And so, how would you describe this picture? Who wants to take a stab at that? Yes. Okay. You're way back there. You need to speak up louder. I can hear you.
The most prevalent cancer is lung cancer.
Okay, and why do you say that?
It increased over the 90s.
Mm-hmm.
It started dropping in the 2000s. I presume due to COVID campaign.
Mm-hmm. Right, and so in this picture, lung cancer, the gray line, is higher than all of the other lines there. And that can be one description of that picture. What other ways to describe the picture?
Just that all of them are either constant or increasing except for stomach.
And what's happening?
It's
Decreasing. And you can be even more specific by adding information from the bottom of the graph. Tell us that maybe stomach cancer from 1930 through 1975 or so is decreasing over time, and then we might beginning to see, no, actually, maybe all the way through 2005. It looks like it's almost continues to decrease. Been an increase in pancreatic cancer from 1930 to about 1970 in men, among men in the U.S. So they're just very interesting to look at. Okay, but this is providing you with single pieces of information about stomach cancer or prostate cancer. Then you can begin to make your story more interesting by thinking about other things or other influences that may be present in the population that contribute to the rises, the falls in these lines over time. Can't say much necessarily about the lines that are going relatively straight across, but what's causing that, or what could be associated with the increase or the rise in lung cancer? Smoking, okay, and that would be at the same time that we're reporting death rates, or what do we need to consider? Mm-hmm.
I'm not sure, like, when tobacco laws was about, when did it all come?
Oh gosh, it's been there forever.
Like, it's obviously a process for the death, so it could phase through the next three and all of them dying by later.
Mm-hmm. Mm-hmm. Yeah. Right. And so the smoking, the risk factor would have occurred many years before the increase that we're seeing in death. Perhaps something more current is the decrease in smoking rates, which came first for men. About the time that we're seeing lower rates of smoking for men, we're seeing increased cigarette smoking rates for women. But so the decrease in smoking rates may contribute to the decrease in the gray line for lung cancer. Yes.
I think also the Industrial Revolution and kind of all the emissions and things like that are going to add to the rise of lung cancer and over that period of time?
Sure. And so we need to think of the history, what are the events that are occurring in the population, and in this case it's the United States, and sort of layer it on this graph and begin to come up with hypotheses. We're not saying that the statements that we're making are necessarily true, but they're hypotheses that we can test by using these data. Yes?
So I know that now, normally in the U.S., chronic diseases have cause of death. But like 1930, that somewhere in there, like infectious diseases would have been more. So could those rates potentially have been higher than, like, if infectious disease kill off, like, number of people would have developed and who would see that?
Right. So we're having what is called competing causes of death. And it also came into a little bit of an explanation that I believe that you're addressing in terms of the proportionate mortality. Sometimes infectious diseases is taking up a larger proportion of deaths during a certain period of time versus later on when, at least in the United States, our top causes of death are chronic disease versus infectious disease, which individuals were dying at a younger age, and so they were not at risk of being a cancer case, but if they had lived, perhaps they would have been cancer. Yeah.
I'm just wondering when the standard of reporting cause of death, like, I know we were reading previous chapters, they kind of have vague explanations for cause of death. Like, was the standard where what they said was cause of death likely? Was that in the 30s, or was that before? Because it's a huge jump, but I feel like people smoked in the 30s, like even.
Yes, but the average life expectancy is much lower. And so there were proportionately deaths from infectious diseases was much higher than the cancer. And, unfortunately, now we're all living longer. We're at risk of cancer. Anyway, the patterns are interesting. You can come up with some interesting stories and interesting hypotheses. Now, another factor that you always need to question is the reliability and the validity of the data. Where are the data coming from? And being aware of how the data are collected. We do have read about the death certificate and how that information is recorded. That's where we get our death rates for the U.S. It's a process that has been in existence for so many years. We do feel confident that the rates that we see in the United States are precise, reliable, and valid. And then we have a similar picture for women, but certainly a different picture. We lay the two graphs on top of each other. They would not tell the same story. We mentioned a little bit about the later time of increase in cigarette smoking for women, and now leading to higher number of cases of lung cancer, and then certainly death rates increasing. And then leading causes of death for all ages. Once again, not significant, highly significant changes from 1950 to 2003. We're seeing cardiovascular disease, including stroke, changing both by results in changing lifestyles and also medical or clinical intervention, access to cholesterol-lowering drugs, for example, is certainly more prevalent, though there is still a significantly large proportion of the population that is unaware of their blood pressure. And so sort of the hidden disease, not knowing that they actually have high blood pressure because normally there are no signs or symptoms, and then but they are walking around at risk for heart attack, stroke. You know, we still haven't won the war on cancer, which was announced during Nixon administration. Still fairly all-cause cancer, still fairly stable across time. Unintentional injuries. Now, remember, this is one picture, but if we had a picture for males, a picture for females, it may be different, and it certainly would be very different for pediatric ages versus adult ages, where you begin to see your injury as your number one cause of death during childhood. Now here we have a real success story in terms of the work that has been done in the United States for decreasing mortality rates during infancy, neonatal period, and post-neonatal period. Are you folks familiar with what is called healthy people, like 2020? Okay, those we often use those benchmarks for our intervention programs, and you will always see infant mortality rate as one of the benchmarks for maternal child health, just about, you know, for injury prevention, nutrition, obesity. There are various benchmarks for which every 10 years we say, okay, we are at this rate now, we're at, you know, 9 per 1,000 lives births now. In 10 years, we want to get to 7. And so that's how those are reported and determined. What's the definition of infant mortality? Yes.
Isn't it within the first 5 years?
Actually, it's within the first just 1 year. The first year, infant mortality within the first year of life, and then that is divided into neonatal and post-neonatal. And how about neonatal? I'm sorry?
Below 28 days.
That's correct. Yes, before 28 days. And so your post-neonatal is 28 days to 1 year. Thanks. Yes. And the reason why we are interested into breaking down those rates so finely is it gives us a clue in terms of what we might be battling in terms of death from what and what can we do to lower that rate. If it's death before 28 days, it may be because of a short gestation. low birth weight, congenital malformation, whereas those deaths between 28 days and 1 year are more generally related to sudden infant death syndrome or SIDS. And so by being more specific and breaking your rates down, that also allows you a tool to monitor an intervention program. And so let's say we rolled out an intervention program for SIDS for the state of Tennessee. We would then use as one of our evaluation tools the post-neonatal mortality rate, and we would look across year after year to see if we could lower that rate, and if that rate went down, we could potentially say that we had a successful intervention program statewide that allowed us to decrease the number of deaths due to SIDS. Mortality rates, they're calculated like any other rate is calculated. You've got your numerator, your denominator, all within a period of time times a constant. You can age adjust your mortality rate. Annual mortality rate for all causes. So we've got numerator, we want all causes of death. Because it's a rate, we want a period of time. All causes of death in a 1 year period. Numerator, I mentioned, very common to use number of persons in the population at mid-year, or we often use census tract data. U.S. Census every 10 years, but we are able to adjust, project population between census. So that might be a figure that we would use for the denominator, multiplied by a constant. They can be, the mortality rates can be age-specific. Numerator, number of deaths, all causes, within a certain period of time, 1 year, adults 50 and older. Now, once you start getting into your specific rates, you want to make sure that your denominator matches your numerator, and your numerator matches your denominator. So you see that we're getting into age-specific rate. We're no longer using number of persons in the population at mid-year as we were for the first rate, but we're interested in an age-specific of 50 years and over. So in the denominator, we just put those individuals that meet that criteria. Otherwise, would we overestimate or would we underestimate mortality rate? Yes, we would underestimate because we would have our denominator would be too large. Okay, and we would have this number up here, but a big number down here. We need to get only those 50 years or older, which makes a smaller population. So that, you see how that would dilute out the true rate. So make sure that you have an appropriate denominator. Cause-specific mortality rate, number of deaths from lung cancer in a specific period of time, 1 year over number of persons in the population at mid-year. time to constant, and then cause and age specific. So you have number of deaths from lung cancer, 1 year, adults 50 years and over, with a matching denominator of number of persons in the population older than 50 at mid-year. So examples of annual mortality rate, age-specific, cause-specific, and cause and age-specific. As you add more and more strata or more and more variables to those specific rates, your rates can become imprecise because you have a smaller number of individuals, both in the denominator and the numerator. Your confidence intervals around an imprecise mortality rate would be wide or wider. Another mortality rate, a case fatality rate, where we are now putting diagnosed cases of the disease in the denominator. And so only diagnosed cases of the disease are at risk of becoming a numerator. You have to have the disease in order to die from the disease. That's basically what that concept is, a case fatality rate. You need to have the disease before you can die from the disease.
I have a question about like what the time period usually looks like for cases. I think in the reading, I can't remember which chapter, but it talks about fatality rates happening for some diseases more at one time of year than another, or so is there like a general period of time to look at it? Or probably
oh, that's a great question. That's interesting. And to get the full picture and to see if that effect of seasons is actually having an influence on case fatality, we would like to see a full year, so that we can then say, okay, first part of the year, is the case fatality rate the same as the end of the year? So yes, we would like to see the full year.
So then, would you do like the entire year just this year, or would you break it up into like 3-month intervals so that you could tell? Okay.
Sure. You would do, as long as you've collected for the whole year, you can then break it down to month by month, 3 months by 3 months by 3 months. And so, as long as you collect the data appropriately, that you have the data set, so that you can break your data down and ask those interesting questions. And then the case fatality rate is more useful for something that's happening quicker than drawn out as chronic diseases are. Now, remember that case fatality rate is another one of those tricky uses of words. It is not a rate, it's proportion. The proportion of people with a specific disease who will die of that disease within a defined period of time after diagnosis. So another piece of information to contrast as you reading, what is the purpose of case fatality? it really provides you with information on severity of disease, whereas mortality rate or real true rate provides you with information on risk. Case fatality rates, we are going to be using when we are suspect an epidemic, a pandemic. Those often travel quickly, both in terms of across geographic areas and within time. And so we are going to be using our case fatality rate to give us information on how severe the strain of viruses, for example. We've had, many experiences, current experience with SARS or avian influenza, Ebola. Perhaps, West Nile. We don't know. Why the epidemiologists in North Carolina are going to be looking for cases and monitoring that case fatality rate. And so we have another proportion that was introduced in this chapter, proportionate or proportional mortality, whatever you'd like to call it. You have number of total deaths during a time period for your denominator, and number of deaths from a specific cause during a specified time period. And so to get the various percentages, number of deaths from cancer, number of deaths from cardiovascular disease, number of deaths from injury, what percentage are each of those three types of deaths over the same denominator data? Okay, you're just you've got your total deaths, which would be 100%, and now you're just partitioning those 100% of your deaths, and you're partitioning them into, okay, what percent was stroke, what percent was cancer, what percent was injury. And a useful indicator of burden of disease is the proportionate mortality changing over time, changing over place, changing over person, place, time. Remember, we're always questioning person, place, and time. Does the pattern change by person? Is it changing for men, for women, across time, place, in some geographic areas? Because it's a proportion, it cannot be a rate. Once again, stressing mortality rate measures risk. Proportionate mortality does not, because it is a percent or a proportion. And even to add more confusion, sometimes it's called a proportionate mortality rate, sometimes it's called a proportionate mortality ratio. But just whatever it's called, it's a proportion, it's not a rate. That's where you really want to focus in on. an example of calculating mortality rate and proportionate mortality so that you can see why these differ. You're using different pieces of information, and so you've got total deaths from all causes, 50,000. Of those 50,000 deaths, 20,000 were from cause X. So we got 50,000, 20,000 from cause X, 30,000 from all other causes. 20 plus 30 gives you your total 50. And then you have a total population of 400,000. And so your mortality rate for cause X, what is in the denominator for a rate? Your total population. And if you want your mortality rate for cause X, what's the numerator? 20,000. With a per 100,000, you have a mortality rate of 5,000. And if you are calculating proportionate mortality, what is the denominator total deaths from all causes? The 50,000. And of that 50,000 deaths from cause X, just a proportion, 20,000 is what portion or what percent of all deaths from all causes to 50,000, and it's 40%. So we're using different pieces of information, and that's why the rate is different from the proportion, the percentage. Then we learned a little bit about years of potential life loss. These type of figures are commonly used by insurance companies for establishing rates in which they are going to reimburse some things. Can be used in court cases, for example, if it's a negligent death. It's one of those things that you really don't almost want to start talking about, but what is a life worth? And so it is the value of human life and economic implications of premature death. And by calculating years of potential life loss can give you an idea of which diseases cause more premature death, because we certainly want to make sure, or we want to intervene. There should not be a reason for premature death. And we know that in terms of when we speak about health disparities, premature death is often a concept that we speak of. Why is life expectancy of a 30-year-old white male higher than a 30-year-old black male? Because we have that difference in life expectancy, it's a health disparity. And what we're trying to do is intervene so that there are no health disparities and intervene for premature death. All for benefit society's increased productivity. So it's an economic term. You've learned that there's 2 steps in determining years of potential life loss. 75 is a common cutoff used. Another age younger or lower. If the person is the same age or older than the predetermined age is 75, there are no years of potential life lost for that story. And then the second step, the years of potential life lost for each individual are added up for the cause of death in the population being studied. And so you can compare the YPLL for different causes of death within a single population. So those counts that you come up, what's the YPLL associated with cancer, associated with stroke, associated with injury. So that's within a single population. What you should not be doing is comparing your years of potential life loss between or among populations. Because we know that unless you think that the populations that you're comparing are very similar or exact, and most often that's not going to be the case. The example that we were using primarily in Chapter 4, populations have different distributions of age. And so some populations are older in general than other populations. We think about the states of Florida, Arizona, Texas, common places, common retirement areas, older populations. And so we should not be comparing them to California or other states that might have younger populations, because we would expect more deaths in older populations. They can be adjusted just as we learned age adjustment for race. What are we trying to put here? Okay. As would be expected, causes of death that have higher years of potential life loss are those that are more likely to happen in younger individuals, because there's going to be more years that contribute to that total count. So years of potential life loss indicates the importance of a cause of death for premature death. It can provide useful information when considering how to use limited resources when developing prevention programs. And that really is the key for public health programs, public health departments. They're always under-resourced and always having to really keenly determine where the resources should go. I think that is a very informative time with Affordable Care Act being implemented across the United States. Much more focus on prevention, primary prevention, secondary prevention, keeping individuals out of hospitals, keeping individuals healthy. And so many more of the responsibilities and activities are being shifted to the public health provider. And unfortunately, the economic resources aren't following in that direction. And so we will be studying the influence of the Affordable Care Act on human health for many, many years. It is an intervention. It basically is an intervention. It will be not a controlled intervention, observational. We will be able to study it as a cohort study as long as we are keeping track of the various layers of, okay, for example, what year did this state implement this policy? What year did this state implement the same policy? Is it working in a similar fashion between states? So there's some very fascinating questions that go along with the implementation of Affordable Care Act. Well, as with any database, there can be problems with it. You should never take data face value. You should be asking questions. Where is the data coming from? How are they being maintained? Were there any changes to the data? Who made the changes? When were the changes made? Why were the changes made? You saw in the an example, a simile of a birth certificate was included in Chapter 4. Those are standard certificates. They are used across the United States just as birth certificates. We have standard birth certificates that are used across the United States and collected so that it can be a national resource for us. But we do know we're currently evaluating birth certificate data for Tennessee, and we need to realize that some of the data are collected from medical records, some of the data are collected from moms, some of the data are sort of collected from mom, some of the data are missing, and so we just need to be aware of the limitations of our data. I'm not saying that you can't use it, but you need to be aware of the limitations. And when we write results of our research projects for publications, we always have a section of limitations. The limitations of the study, the limitations of the data. We would all love to do a perfect study. It's next to impossible when you're working with human subjects, when you're working with data that are collected by humans, data that are generated by humans, and that's one of the most frustrating things of finishing a degree program, learning about, the perfect study out of books, the perfect cohort study and case control study, and then you get out to the real world and you realize, well, okay, we're going to have to tweak it here, tweak it there, but just as long as you know limitations, sometimes you can weight your data. You can potentially impute data or missing data. So there are some things that you can do to increase the robustness of the data set if you think there are problems with it. I would say quality of death certificate data varies from place to place. I would say that globally, not necessarily within the U.S., certainly globally. The one thing, yes, when we do have ICD-9 changes, it takes a few years for everybody to catch up to the changes. They don't change. Everybody doesn't change at the same time. We sort of put it into process and procedure, and you usually end up having to have a footnote underneath any figure that is displaying data at the time when the changes went on record and wait for a couple of years for all of that to settle down. Lots of types of rates, crude rates, specific rates, adjusted rates. We've alluded to the specific rates, age-specific rates. Then there are adjusted rates. How do you understand the concept of adjusted rates?
That applies to the numerator.
I'm sorry?
I don't know. Never mind. Okay. I was just gonna.
Yeah, sure. Okay to think aloud. That's how we solve many of our problems. Think aloud and say to yourself, no, I didn't mean that. Right.
Instead of studying the entire population, you study the subset of it, right? That's how you adjust the rate as you take out a certain group from the population that you're studying.
You know, I would label that as specific rate. All right, specific to a subgroup, specific rate. Okay. Yes.
You want to study a subpopulation in two different populations that have different age structures, so you would want to apply the rate to a standardized population to compare.
Okay. A standard population, use of a standard population. Okay, so I'm going to step away from a subpopulation that you interjected into your explanation, because you just mentioned subpopulation and I told you, yeah, specific rates. Don't want to confuse folks. Okay, adjusted rates. All right. So you are looking at this some different which is different subpopulation. Sorry. You know, these terms are very confusing. I understand. All right, so you've got population A, population B. Let's go back to the example of older populations versus younger populations. We're looking at, okay, everybody's retiring to Florida. Florida has an older population. Okay, there are less children than there are, quote, older adults. Versus, I haven't looked at this yet in terms of specific for Tennessee, but let's say Tennessee has a younger population. Is it fair to compare the mortality rate in Florida compared to the mortality rate in Tennessee? Why? They're different. That whole thing, go back to, I don't know if you folks use this term anymore, like comparing apples to oranges. You just can't do it. You have to compare similar things. And so what we need to do, as you were informing us, you have to take the rates that you have from each of those populations and apply them to a standard population. Okay. A standard population can be anything. It can be U.S. standard population. It could be Florida standard population. It could be Tennessee standard population. It's just that the distribution of age, you're using the same distribution of age for Tennessee, the younger population, as you are for Florida, the older population. And then you are multiplying the standard population by the rates, Florida rates, and by the Tennessee rates. You are adjusting. Oh, I see where this is going.
So it's kind of like in math when you have two fractions and you just change one fraction to match. So you change it so that the denominator is equal. Basically, it's kind of like that.
I like that.
Yeah.
Yeah. Yeah.
Okay. Is our standard population going to be like provided? I want to think about it. Like, how do I know what to use as my standard? I guess.
You can use anything as a standard as long as the standard is used for each of the populations that you're comparing. You could use a U.S. standard. You could, if you have population A, population B, you could use population A as a standard. You could use population B as a standard.
You can actually use one of the populations.
You can use one of the populations. Now remember, then the important thing to remember about adjusted rates is that they are hypothetical rates. Okay. You're going to come up with, you're only calculating them so that you can compare your two populations. Okay. You have your true rate when you use Florida's denominator and Florida's numerator. Those are true rates for Florida. When you use Tennessee's denominator and Tennessee's numerator, those are true rates for Tennessee. Okay. But I want to compare death rates, Tennessee, Florida. But I can't compare because I know that the age distribution differs. So in order to make a statement about comparison of mortality rates, Tennessee versus Florida, I standardize them first. If the information that I get after standardization, I can then, but they're not true rates. Okay, they're for comparison purposes. So, comparing, and then adjust, you can adjust for age, you can adjust for gender, you can adjust for race, you can adjust for ethnicity, and the reason why we are adjusting these rates is because some factors place an individual at a higher risk of death. So, yeah.
When you adjust something, you're reporting those results. You tell what denominator you adjust?
Yes. 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 And you also inform the reader that the rates have been adjusted, and you tell them what they've been adjusted for. As you continue with your biostatistical courses, you're going to get into multivariate analyses where you will be adjusting some statistical estimator by multiple variables. Right now, we're just doing one variable at a time. Now, introducing a new term, confounding. We're trying to adjust to take away an effect on our outcome. There is a variable that is potentially affecting our outcome. That variable that is associated with our independent variable and our outcome is called a confounding factor. And if we do not adjust for confounding, our results are going to be inaccurate. But we're not going any further into confounding today than that. I've got to say something for the next couple of weeks. Confounding. Okay, both specific rates and adjusted rates can be used to remove the effect of confounding. So that's a sort of an easy concept to remember. Specific rates, adjusted rates can control confounding. Okay. Adjusted rates are used to remove The differences due to confounders, or the confounder that we were talking about was distribution of age in a population. Problem with using specific rates to remove the effect of confounding. Sometimes you have too many strata, and you're really not quite sure what the pattern is. Don't worry about that for now. Too much about confounding. Two approaches for adjusting your rates: direct adjusting, indirectly adjusting. Direct adjusted rates, the most common method used for calculating adjusted rates, using your standard population. Indirect adjusted rates is used when you don't have all the information that you need, and so you indirectly adjust them. Standardized mortality ratios, an example of indirectly adjusted rates. Once again, remember that adjusted rates are calculated only for the purpose of comparing two or more populations. You can use your standard population for two populations, three populations, as many populations as you want, just as long as you're using the same standard population. And then adjustment weights the comparison populations as though they both have the same distribution of confounding variable. A question about what population to be used, just as long as it's the same population. Standard population can be the actual population of one of the groups. I'm going through these. These are not providing you with anything in addition to what we've already said. These slides will be available to use. Just sort of repetitive so that it's slowly and comfortably sinks in. Okay, the indirect method is used less commonly. The standardized mortality ratio is an example of an indirect adjustment. Once again, using standard rates from a reference population because you do not have enough information in a population, for example, that would allow us to determine whether or not age does differ between two populations. And we are looking at expected events compared to observed events in the study population. Your formula for your SMR is observed over expected. SMR equals O divided by E. There are specific examples in the text. SMR, once again, the SMR is not a real rate. It's a calculation. And the take-home for the SMR is if your SMR is 1, means that your observed and your expected events are level. If your SMR is greater than 1, because remember, it's just you're dividing observed over expected, and so this is you're going to get 1, you're going to get something over 1 or something less than 1. The health-related, for an SMR greater than 1, the health-related events observed in the study population were greater than expected. Remember, observed, so if your observed number is larger than your expected number, you're going to get an SMR greater than 1. If your observed number is less than your expected number, you're dividing a larger number into a smaller number, then your SMR is less than 1, and less health-related states were observed than expected. So SMR is O over E. Just another method for adjusting rates. The direct method applies confounder-specific numbers of persons of a standard population to the specific rates for each confounder-specific level of the study population, gives an adjusted rate. And then the indirect method used only if the confounder-specific rates of the study populations are not known. If you don't know the rate for individuals 0 to 5, 5 to 10, 11 to 15, et cetera, when you don't have all that very specific, age-specific data, then you can adjust by using an indirect method. Have a break. Yes. Question.
Sorry. Maybe we can get back. We do an example with actual math.
Okay.
Like comparing the two, because I'm not quite understanding how if you end up multiplying it by the same number then anyway, how to show you anything different.
Okay. That's fine. That's fine.
I'm okay with that. I think we should do a different way. Yeah.
Right. You have we have to observe this. You have to. You don't have to. Yeah. Right. Okay, this is last slide here, just what we are, a reminder for week 4, you're still working on exercise 1, or maybe some of you have finished it. It's due on the 22nd of this month. There is a Dropbox in D2L specifically for exercise 1. Go ahead and take quiz number 3. If you're having technical difficulties, please continue to inform us, either myself or Yang. There's going to be a new discussion topic on the discussion board during week 4. We'll proceed with chapter 5, and remember to continue to mark down those items that you either have a question about or you want more information on. And then next week. All right, so we have a question about calculating direct rates.
Either one.
Okay.
I mean, yeah. And I see there's an example on page 78.
Yes.
But, yeah, you could maybe just look at that.
Right. That's, let me see. Let me see first. I may have those. All right. So, all right, folks. We're gonna. For those of you who have your text, we're gonna use that right now. Page 78. Share with the individual sitting next to you if you can. So, table 4.4-9. We have comparison of total death rates in a population at 2 different times. And so here it's the same population, but looks like we've got some longitudinal data on them, terms of the early period and a later period. At each point in time, there's a total population of 900,000. During the early period, there were 862 deaths for a death rate of 96 per 100,000. A later period, there were 1,130 deaths with a death rate of 126 per 100,000. So, with that information alone, the death rate in the later period was greater than the death rate in the early period. Okay, but we have to ask ourselves, can we do this? Is it appropriate? Do we know that the 2 populations were the same during the early period and the later period? Well, lucky for us, in table 4-10, we have further information. We have a breakdown of the population. Of the 900,000, we see in the early period, 500,000 were 30 to 49, 300,000 were 50 to 69, and 100,000 were 70 plus. If we look at the later period, we learn it's an older population. There are more individuals that are 70 plus, and there are less individuals compared to the early period that are 30 to 49. So that's the information that we need to now say, okay, you just cannot compare those rates as we calculated in table 4-9. the population age distribution differs between the early period and the later period. So let's now use a standard population so that we can come up with a hypothetical rate that will allow us to compare the early period and the later period. And so what we do is we use the true rates that were calculated during the early period and the later period. True rates. But now we use a standard denominator. Okay, so that the distribution of age is now the same in the early period and the late period. Once again, hypothetical. This did not. These are not the true numbers. The true numbers are in 4-10, but we want to be able to compare the rates. So if we use a standard population, you see that in table 4-11, you've got 30 to 49 years of age, 800,000, 50 to 69, 700,000, 70 plus, 300,000. We use that standard population, and we use the rates that we got in table 4-10, sort of the real rate, and we calculate an expected number of deaths using the new denominator data and the age-specific mortality rate per 100,000. Okay? So that's, we had 12 per 100,000 in the 30 to 49 age group in the early period. That's 12 per 100,000. Our new denominator is 800,000. So we multiply 8 times 12 to get the 96 expected. Okay? We know the true rate is 12 per 100,000. Okay? So now we're just saying, okay, so if we have 800,000 and we know the true rate is 12 per 100,000, 100,000 goes into 800,000, 8 times, 12 times 8 will give you the 96. Okay? Do the same thing for the other two age categories, same principle. Do the calculations for the later period, same principle. And then we've got, now we have calculated the expected number of deaths using the standard population. We've got a total of 2,238 over the standard total population of 1,800,000 with an age-adjusted rate for the total population of 124.3 versus 101.7. And so that's expected because we know that the later period population was younger. They do. Actually, the death rate is less. But the death rate of 124.3 versus 101.7, hypothetical, it's for comparison purposes only. The true rates are in table 4-10. But when we want to compare populations that have different distributions of a certain factor, standardize them, and use the standardized rates to compare. Does that make sense?
So it's super helpful, and so the standard population isn't just a random number though, because they're adding you know, so it's still proportional. Like, you wouldn't want a standard population rate to calculate the expected number of deaths that wasn't truly reflective of the age discrepancy, right? So, like, here in this last table, for people ages 70 plus, you wouldn't want that number to be higher than 30 to 40, you know, so they're adding together early and late in this example.
It doesn't matter what your standard population distribution is because you're applying the same distribution. It's almost like a constant. You're applying the same distribution to both populations.
But the expected number of deaths changes based on...
It does, yes,
right?
yes.
How do those numbers still make, does this still make sense if you were to jumble around your standard population numbers in this last table, even if like 70 plus was way higher?
Yes, as long as we use the same standard population.
For early and late.
That's correct.
Okay.
That's correct.
Okay.
Yeah. Okay, good. Okay. Let's just, I thought, this was a fun little exercise, I thought, in terms of thinking about causing interest. And I've got a copy of the article, Television Viewing and Initiation of Smoking Among Youth, that is also available on your browser. A copy of the exercise, and then a classic article, the Bradford Hill criteria for causation. This is perhaps one of the first articles that came out in terms of causation criteria that were used, but then as the science of epidemiology evolved, we realized we could no longer use the Hill criteria for causation because we began to understand that there's not just one thing that causes a disease, and we refer to it as the web of causation, and it obviously makes things much more complicated, but truer to what actually happens in human populations. And so if you would like to divide up in groups and discuss this among yourselves, please do. We'll be at the, I'll provide you with answers to the questions as I see you go forward with the exercise. And before you start, are there any questions, additional questions from today regarding any of the 4 chapters that you've reviewed thus far, or any logistical questions, administrative questions?
What do we have to do to interview the formula?
Actually, great time for that question because I am reviewing the exam. I've got that one of my things to do over the weekend, and they review the exam, take that question into consideration, and go from there. So.
It's not lazy.
No, I understand. The subject is not closed, but I will continue to consider it. I have not shut the door.
Yeah.
Yes, I'm sorry. Yes, it's the causal inference has an introduction, similar in objectives. It refers to the journal article. It refers to Hill's criteria, And then there are a few questions within the exercise. It's a fun little exercise. Oh, yes, please. Yes. Just as a warning, the lights are going on, so if you're sleepy, it's time to get up. Yeah, that's good. You're going to you guys read through that's the first one.
Right.
And there wasn't really the fact that you did look at that he did and looked at say so. Yeah. I don't know about how do you tell he said he was looking at things, but he didn't really like that's probably like the chief in his whole lifetime. And like that was even if we're going to what was you saying specifically trying to shows which according to the facts finding the store population in order to yeah, I mean, they're obviously like there's that doesn't mean that they're positive. That's what I'm always like do we all agree on the I don't know about the contract. Okay, the contract that one relationship due to the presence of which is the actual contract. Okay, you say that people have matches I see. Smoking is not one part. Yeah, the actual cause of the language, I don't but thank you for so they are doing the study. It's like throughout the rainforest element where you forget that one factor. You're like, oh yeah, that's the cause. It's like comparing old and which I'll say that I could quote a you know what we're both like I can't find the stuff I'm making like chocolate but they didn't or anything we'll talk about one more chance in the building right?
Let's quickly go through some of the answers. Starting with number one, which of the following statements best explains the mayor's false belief that increasing stork population would increase the birth rate? B, I hear B. Yeah, association doesn't necessarily imply causation. There could be alternate explanations for the association, actually a third factor, and actually someone brought this up earlier today in terms of the Industrial Revolution, is causing both a decrease in storks and a decrease in the birth rate.
So for this reason, like, I'm just confused as to how they're, just because they're on the same graph, but they're statistically associated, or?
Right. In terms of they are both decreasing at the same time, okay? And that's really what their association is in terms of the pattern that you're seeing. They're both decreasing, and so the mayor thought that there was a causal association.
So you could add in like any other thing that's decreasing and still say that it's okay.
Yeah.
Right. But I didn't know if I was supposed to assume that the mayor.
There you go. That crazy mayor. No, thank you. Okay. How about iPod? You are struck with the manager's claim that iPod did not cause the team to lose the game. Which of the following could have also caused the risk factors to lose the game? C. B is correct. C. C. Both A and B. The point trying to getting across here is that there's multiple causes operating, and what I refer to as the web of causation. And so now, in terms of epidemiology, we're trying to determine whether it is a cause of disease, not necessarily the cause of a disease. And so, just review the pie charts in terms of sufficient and necessary, or neither necessary nor sufficient. Let's see. Okay, all individuals with, attorney Mike, General Mike, ask you if you can think watching television is a cause of early smoking initiation. That's based on the journal article. You think back to your principles of epidemiology class and recall that epidemiologists have a fairly distinct definition of cause. Which of the following statements best describe the hypothesized causal link between television viewing and smoking initiation? B. Yes. The statement allows for a multi-causal theory of causation. While TV watching is neither necessary nor sufficient, it is still hypothesized to be a cause. All right, so now you've got some Rothman causal pies to help you think about how watching television might act as a cause of smoking initiation. Based on the causal pies given below, assuming they are true, which of the following is a true statement? C. Correct. Television watching is a cause of smoking initiation that is neither necessary nor sufficient. Let's see. The authors state in the results, controlling for baseline characteristics, youth who watched greater than 5 hours of television per day were approximately 6 times more likely to initiate smoking behaviors than those youth who watched 0 to 2 hours per day. What does this piece of information tell us? Yes, there is a statistical association between watching greater than 5 hours of television per day and initiation of smoking after taking into account other baseline characteristics of youth who watched television that were measured in this study. Let's
some of the information needed to answer 6 was cut out, so I'm going to skip that one, and let's go to the last one, number 7. Which of the following alternative explanations could have possibly caused the authors to find that youth who watch greater than 5 hours of television per day were 6 times more likely to initiate smoking behaviors if watching TV did not truly cause smoking initiation? Okay. Yes. Yes.
What was the answer?
What was the answer to 6? C. Yeah, okay, there you go. Very good. All right, thanks, everybody. That's see you in the class. Have a good week. See you next week.
Thank you.
Oh, great. Thanks so much.